Okay, here we go. I believe this is where we left off last time with the discussion about 3D volumetric airway and what that means to us as we practice today. And basically, it's a screening tool, not a diagnostic tool. So you can see changes before and after expansion. This was my son's case again. But again, a lot of this may be postural changes, meaning that in one image we took, the head was more back, and then the other image, the head was more forward. But talking about that, I mean, when you hear about the term like forward head posture and why that happens, it's purely anatomical, right? So like kids who have forward air posture, it's easier for them to breathe, just like it is for any of us. If we can have good posture and breathe normally, you know, we have a great airway. If it's constricted here, then we're going to go here, okay? So that's how those two things are connected. It's purely anatomical. When the head moves forward, the airway opens up. Okay, so let's dive in and we'll see what we remembered from last time, and also let's go through a few new cases together and kind of diagnose these, and then we will go from there. We might get to space analysis today. We might get to some other things as well, depending on how quickly we get through these things. So overall, just start with your orthodontic diagnoses. What are you seeing? Like anything. Just spit out something that you're seeing on here. Anything potentially out of the range of normal. If nobody answers, we'll just call on the birthday girl every time for everything. What's that? Deep bite. Okay, so deep bite. And we can see that, right? We can see the overlap of the incisors in the front. There we go. We'll get this close. Right? So there's an increased overbite or a deep bite. So when we diagnose a deep bite, what are we always going to look for? So it's potentially associated with every deep bite, something that if we don't correct could get worse over time, especially in younger patients. Yeah, pathway wear, some type of wear in the lower anterior incisors. So we look here, you know, I don't have a center open photo here. Doesn't look too severe from the incisal edge here. A lot of times when you see that wear, it'll look thicker. But again, not the best images to see that, but you're going to look for where. If you see it, you're going to inform the patient, inform the parent, okay? That's something that matters to them. I've had hygienist kids come to me when they're 12 or 13 for the first time, and they have wear on the lower incisors. And the thing of it is that they used to be tipped forward, tipped in and everything, and then when they come in now, it's like worn off straight across. And so then I have to be the person that tells them, hey, when we straighten these, they're going to look like shark teeth because they were crooked and then they got worn flat, and now when we upright them and get the roots in the right spot, they're not going to look good. So deep bite, you're always going to talk about, check for the incisal wear on the bottom, okay? What other diagnoses do you see in this patient here? Okay, and why do we have excessive overjet, would you say? Like what? Because excessive overjet can be one of really four things, right? It can be a protrusive maxilla, a retrusive mandible, proclined incisors, retroclined lower incisors, all right? So it's going to be a combination of those things, right? So when we look at this case specifically, which of those things apply? Say that again. Okay, so the mandible is retrusive, right? You can see the lower jaw, and what besides just looking at it and saying, yeah, that's retrusive, what specific characteristics do you see that says, yes, this is a retruded mandible? Okay, you're pointing to it, so what is that? Help her out, what is this? Yeah, the mentolabial fold, right? And what about this mentolabial fold indicates that it may be a retrusive mandible? Yeah, it's deep or acute, or you see the turned lip, okay? So that's one indicator. What's another indicator? For the retrusive mandible, what's another indicator? Maybe more down in this area here. Well, you have a length that you can see, right? You can see the length from the chin to the throat here, right? So the chin, throat, neck length here, this is something that you can look at objectively and say, does this look shorter than normal or does this look longer than normal, right? So again, we haven't looked at any x-rays yet, but we can see maybe this looks a little shorter than normal. There's one more thing, and this doesn't happen with every single retrusive mandible case, but it certainly can. It has to do with being able to get the lips together when you have a retruded mandible. What might happen if it's really retruded and the lips have a hard time coming together normally? Yeah, you might have mental strain, right? So you can kind of see these muscles pursed here, okay? So all three of those little indicators would tell you, okay, well, maybe this excessive overjet is due to a retrusive mandible, okay? Let's talk about the maxilla. Is that, what would you say about the maxilla? Is it in a good position? Is it protrusive? Because we said that's a possibility for overjet, right? Is it retrusive? What's going on with the maxilla? Looks good? Okay, I heard it looks good to me, okay? So what about it looks good? When you look at the features of the maxilla, what you can see here, what about it looks good? What are you seeing that says, yeah, this looks good or this looks normal? Okay, so you have the nasolabial fold. And what about the nasolabial fold here? What's that? Yeah, it's full, right? So it is a little bit obtuse, but why is it obtuse? Yeah, the upward nose, right? So if this nose were not quite as upturned, this angle would not be quite as obtuse. And even with the upturned nose, it's still probably not much over 90 degrees, right? Which is, quote unquote, relatively in the normal range. And so looking at the lip support here, you can see, if you just took a line and drew it straight across here and just saw the upper lip, you would think that's pretty ideal, okay? So, with the jaws being, upper jaw being relatively normal AP, lower jaw being recessed, what about the proclination or retroclination of the teeth? Is that affecting our overjet in a negative or positive way? And again, I'm not showing you a Ceph, but just kind of look at these images and what do you think? Like the upper incisors, for instance, are those proclined, retroclined, pretty good? Yeah, they look pretty good, right? So you're not seeing, like down here at this image, besides this lateral incisor here, you're not seeing an excessive amount of the lingual surface here. When you're looking at the arch form as a whole, yeah, they might be a little proclined, and again, we'll see that on the Ceph soon. You have a little bit of spacing, which again might indicate a little proclination, but certainly you're not seeing, proclined teeth that are just way out there and that you get really worried about from a trauma standpoint. What about the lower incisors? Do they look proclined or retroclined? What's that? I think I heard it. Yeah. If anything, they're proclined. And you look at that, right? You see more of the lingual surface. You see the incisal edge past where the bone and gums are, and you see some spacing down there. So if anything, these lower incisors are kind of camouflaging how much overjet might really be there once those lower incisors were uprighted. Now, when we talk about proclined lower incisors, what's something else that we always want to look for and pay attention to and make the patient and parent aware of? And it could be uppers as well, but we see it more often on the lower incisors and more often on retrodactic mandibles. What can happen if whatever it is, the tongue or just the way the bite fits, pushes those lower incisors more forward, more forward, more forward? What do we want to watch out for? Yeah, you want to watch out for recession, right? Because the more forward they go, the less bone support they have. So you want to watch out for recession and or thin gingiva. Right? If they have really thin gingiva, you want to educate them. What do you want to educate them about? What do they need to know right now if they have really thin gingiva? Okay, nobody's done any orthodontics on this person, right? But they come in, and for whatever reason, the way they develop, maybe genetics, maybe physiological, the teeth going forward, whatever it is, their lower incisors are proclined, the gingiva is very, very thin. What do you want to educate them about? Okay, the risks of what? Okay, that's fine, the risk of recession, but what do they really want to know? Like, what matters to them? What's going to change their behavior between then and later if they know something versus not knowing something about this? Like, what do they need to know to limit their risks? I mean, the risks are important to know, but what do they need to know to limit the risks? What's that? Yeah, what about oral hygiene? Yeah, okay, so, yes, keep the teeth clean. Okay, so you tell them, hey, you need to keep those teeth super clean. Like some people, they have thick gums and they'll hold up really well, but yours are really thin. You got to keep it super clean. And so they go out to the store and like, I'm going to keep this super clean. They're looking at the toothbrushes. They're like, oh, soft, medium, firm. Firm's got to be better. I'm going to grab that. And they look at the toothpaste and like, oh, extra strong, like whitening. If it's whitening, it's probably cleaning better. And so they grab those and just go to town. Is that good? Okay, so what are we going to educate the patients about? Because I promise you, if you just tell them to keep it clean, you're going to have more people go that way than would go the proper way, which is what? Yeah, soft bristle toothbrushes, right? Because we don't want to aggravate. We need to keep it clean, but we don't want to aggressively actually damage the gums with the hygiene protocol, right? Patients are not going to know this unless you explain it to them, right? And you're not going to explain it to them unless you're looking for it. So when you see those thin gingiva, first thing, talk to them about it, let them know, say, hey, look, it's a really delicate balance between keeping everything clean and not brushing or flossing so aggressively that it's actually damaging and causing worse problems, okay? When I was in college, my back teeth started to become sensitive, and I was like, what the heck is going on? Like, I mean, I feel like I'm brushing my teeth, so I'm like, man, I guess I got to brush them harder. And I had a medium bristle toothbrush, and finally I went to the dentist, and he showed me the recession that I've caused, which I still have to this day, from improper hygiene, right? From brushing too hard, okay? So when we see these things, again, talk to the patients about it in the way that they'll understand and give them the information they need so that they're not going to make the problem worse, okay? So we have overjet. Let's keep going with diagnosis. What else do you see here? Okay, so class 2, and that's class 2 what? Class 2 division, what? Huh? You got a 50-50 chance here. What? I heard 1? Who said 1? All right, yes, class 2 division 1, right? Because we have, as we mentioned, if anything, more proclined incisors, not upright incisors. So we have class 2 division 1. Does that tell us really anything else besides what we already knew about the retroclined mandible and the overjet? It's kind of just another way to say it, right? Okay, so that's fine. Let's move away from the AP. All right, let's look at some other facets of this case. Well, what do you like about it? Let's start there. What do you like when you look at this patient? Like, what looks really good to you? Like, what would you not want to change? We talked about the maxillary. Go ahead. What else? Okay, so there's a pretty full smile, right? So when we look up here, you can see the buccal corridors look pretty small, full. What else about the smile do you like? Okay, so the midlines are pretty well established. Okay, that's good. So there's probably not some weird shift going on from left to right, so that's good. What else do you like? Yeah, the smile. They have some natural, smile arc here, and they have a pretty appropriate amount of gingival display. They're showing all the teeth and just a little bit of the gums. Could it be a little bit more? Yes. Is she smiling all the way? I don't know. We'll get a little bit more of an idea when we look at the Ceph. Okay, so those are some good things. Okay, so what about crowding or not crowding? Where are we at with there? Let's look at the maxilla first. When you look at the maxilla, would you say there's crowding, not crowding? Or if you had to pick well, let's just start there. Crowding or not crowding? All right, so who feels like this? What's that? Okay, we have a mild crowding. All right, does anybody diverge from mild crowding? Okay, so if you had to put a millimeter number to that, what would you say and why? Okay, so 2 millimeters. And how are you coming up with that number? Because I'm not saying it's wrong, all right? So, but how do you come up with that number? Just kind of looking at it? Okay. So we're going to talk either this time or next time about space analysis and how to look at this, but let's start this conversation now. So there's a few kind of landmarks that you can rely on when you're looking at crowding, okay? So first off, when you start with normal things, meaning you have a primary canine, primary first molar, primary second molar, if those 3 teeth are in the arch, then in that area, are you going to have room for the first premolar and second premolar and canine? Yes, right? So that's what those are designed for, right? So the second primary molars are a little bit bigger. The first primary molars are about the same, maybe a tiny bit bigger than the premolars, and then the primary canines are smaller. So you add that all up, assuming you don't lose any space, you're going to have room for the permanent teeth in that quadrant, right? So that helps you to very quickly separate out and try to figure out, okay, well now how much room do I have for the teeth that are in the arch here? So now when you look here, you can see, okay, well this is actually first premolars, and those have enough room. They're about the same as the primary first molar, so that's kind of a wash. These are smaller than the permanent canine. These are bigger. She has all the teeth. We should be fine from canine back. So now all we have to focus on is the incisors. And when we look at the incisors, you noted about 2 millimeters of crowding. If you look at the overlap here, there's probably a millimeter there. If you look at the overlap here, probably a millimeter there. I would agree close to 2 millimeters if we keep the angulation of the incisors where it is. Okay? Now, if we decide we're going to change the angulation of the incisors because we think it's going to look better or fit better with them more proclined or retroclined, well, then that affects the amount of spacing that we have, right? So as we procline, we're going to gain more space, and as we retrocline, we're going to lose more space, okay? So we haven't really made a definitive determination on where we want these teeth in the end, but you have to keep that in mind. In severely proclined or retroclined cases, you want to calculate that in. Okay, so if you move the incisors forward, right, you procline them about 1 millimeter, how much more space are you going to have to resolve crowding? Anybody? We got discussion going on. All right, well, let's just keep it simpler, and we'll have somebody look up the answer. We'll look it up in the literature. But is it more or less than 1 millimeter? It's going to be a little bit more, right? So I think, honestly, I think it's around 1.5 millimeters, all right, either way, right? So if you have to retrocline a millimeter, you need about 1.5 millimeters in space. If you want to procline a millimeter, you'll gain about 1.5 millimeters in space. And it has to do with the arch form, right, not being like a straight line, okay? But if you find a definitive answer and a literature source for that, let's talk about it next time. But just keep in mind it's going to take a little bit more space if they're proclining. You need to retrocline them, and if you can procline them, you'll gain a little bit more space. So in the upper, we mentioned mild crowding, 2 to 3 millimeters. Okay. What about the lower? I mean, it's a little bit harder here, right? Because we don't have the primary teeth. Okay. So we'll talk later about space analysis and some of the traditional methods on how you can actually do this by measuring the incisors that are in the mouth. But to ballpark it, I mean, if you just try to break it up into those quadrants, you can see here, maybe 1, 2, let's say 2, maybe 3 almost millimeters of space, lower 2 to 2. Now again, if those are proclined, we might lose that. If we got to bring them back 2 millimeters, well, that's gone. All right. Now we look on this side. We have the primary canine. You can imagine primary first molar, primary second molar. You can see that second premolar coming in, so that's good. Hopefully that comes in and helps keep this molar back without drifting forward. You can see there's probably enough room for the first premolar here, and then the canine, to be pretty close. On this side, maybe there's slightly more space loss. Hard to say. The molar, again, looking at the photo, could possibly be a little bit more forward. But overall, it's going to be pretty close. You can see we definitely have lost some space. A primary first molar would not fit here, correct? Yeah, it wouldn't be big enough to fit here. So, maybe a couple millimeters, 1 to 2 millimeters of crowding on this side. And again, it's hard to determine on this side without actually measuring it out. Okay, so we have some mild crowding. All right, so now let's keep going. We have diagnosed this case with probably a good maxilla-ish, all right, a mandible that's retrusive. Procline, possibly lower incisors, maybe upper incisors, maybe a little bit. We'll see when we get to the ceph. We diagnosed a deep bite, which may or may not have significant wear implications on the lower incisor. We can't really see it 100%, but definitely not severe. So how are we going to treat this patient, or what are we going to recommend for treatment for this patient? Or are we not going to recommend treatment for this patient? No one wants to decide. Okay, so basically another way of saying that is like, you're not really seeing anything here that makes you concerned. You're not seeing anything that if we don't intervene or if we don't do something now, that's going to get worse later, okay? Again, if we assume that the lower incisors are wearing down, yeah, maybe you do a Holly with a bite plate that can get them off the lower incisors. They wear it at night. It puts some intrusive force. It allows the posterior teeth to extrude a very small amount at night so that during the day, they don't hit heavier on the front teeth, and you can maintain those incisors not wearing down. You might consider something like that. It would also hold the space in the maxilla in the event that they, lost teeth early, or that you wanted to hold the entire E space because you're a little bit shy on crowding already. You don't want to lose that 1 to 1.5 millimeters as the E's are lost and the molars would normally come forward, okay? So you can look at some type of space maintenance, okay? And then potentially address the AP when the patient gets older, all right? So that's exactly what we did. We gave her an upper Holly with a bite plate, okay? And this is where she came in later with all the permanent teeth in. So, how did Mother Nature do? Pretty good, right? So, the incisors, they don't look terribly proclined. There's a little bit of crowding. We talked about that. We talked about having probably a little bit of crowding in this area. You can see it now, 1, 2, 3, 4, maybe 3 or 4 millimeters of crowding there. A couple millimeters on the top, which is about what we thought. Again, we held the space on the top there. And so at this point, and we got a little bit maybe lucky with Mother Nature, right? She grew more forward into more of a class 1. Didn't have to do anything with that. We still like a lot about her smile, right? An appropriate amount of gingival display. You can see she has a more full smile now. She probably wasn't smiling completely initially. She's got complete passive eruption of all the teeth, all right? So at this point, braces is optional. Aligners are optional, right? How straight do you want the teeth? Really no functional concerns. It looks like maybe at some point she either had some wear or chipped this tooth on the side here. But overall pretty good, right? I mean, yeah, are the jaw relationships perfect or ideal? No, I mean, the lower jaw is still set back relative to the upper jaw. But, I mean, how are you going to correct that, even if you wanted to, right? Occlusion's class 1. So unless you do something extreme like extract lower premolars, pull everything back in a mandibular advancement, right, that's not going to change significantly, okay? And if it's not a concern of the patient, there's really, I mean, that's really just an aesthetic thing, right? Is there any other problem with having a chin that's more recessed? If your bite is fitting together well and you're happy with your smile and you can chew and function, not really, not at all, right? So this is totally optional at this point. She chose to not have treatment. She was happy with her smile. I can't blame her, right? So Mother Nature did a pretty good job here. All right, but let's look at this case. So let's start diagnosing this case. What do you see? Okay, so when we look at, we talked about how we were happy with the buccal corridors in the other patient. In this patient, definitely more of a narrow appearance, okay? So it's on our radar now. We're thinking, okay, well, is there a jaw size discrepancy? Is the upper jaw smaller than the lower jaw? Is that going to affect how much room we have for the erupting permanent teeth? Okay, so this is a clue that the maxilla is smaller. What other clues do you see on these views that the maxilla might be smaller? Okay, so you can see here when you actually look at the palate itself, it looks higher vaulted. It looks very deep. Okay, so why did that happen? All right, maybe genetics to some degree. Maybe what else? What else might have occurred during this child's growth that might have resulted in that happening, and why? Okay, could have been some type of a thumb habit at some point, or finger, or something else. Now, if there was a digit habit, do you think it's still happening now? No, why not? Yeah, the teeth aren't flared. There's not an open bite in the front. In fact, there's a deep bite, right? We talked about that. But for some reason, this developed more vaulted. Again, I'm not saying that it's not genetic. I'm sure genetically there's a component to that, right? There's a good, strong genetic component to all of our growth. But what else could be an environmental factor that might have affected how deep that palate grew and why? I mean, you think about it, right? So you have the same size palate here, right? This palate, and I'm not changing the length of my arms, right? But it can develop more like this, or it can develop more like this, right? Arms are the same length, but it can develop one way or the other, okay? So what might make it develop more like this, which is what we're seeing in a deeper high vault palate, right? What might make that happen? Okay, yeah, so start thinking about it, right? So what makes it happen normal, right? What would make it develop like this? If you can answer this question, then you might be able to answer this one, right? So what makes it develop normally? Well, bone, teeth respond to forces. There are always forces in the mouth, right? When we go back to this case, the reason that these teeth are aligned the way that they are is that they're in perfect physiological balance with all the forces in her mouth. The forces of her cheeks, the forces of her tongue, the forces swallowing, the forces speaking, like all the things that happen to the teeth, there's forces that are applied to them every single day by normal function, and that balance is where the teeth end up, aka the most stable position, okay? So, because you don't have to do anything to maintain it, right? It just is there. So when we look at this patient here and we look at where her most stable position ended up, you can see that there was something probably on the outside that those forces overcame the forces on the inside. So you mentioned the forces on the inside being the tongue, right? So maybe the tongue was not on the roof of the mouth every time she was swallowing, okay? Maybe she had a reverse swallow. Maybe she had some other sort of a functional difference to where when she swallows 600 plus times a day, it doesn't push or provide the same force as that other patient, okay? What else might be a reason why there's more force on the outside than the inside? Okay, it could just be the actual makeup of the muscles themselves. So tight musculature, like where? Like, yeah, so tight musculature on things outside, right? The forces that are applied to the outside of the upper jaw, okay? And let's say the muscles are tight, and or if you think about if the majority of the time the mouth is open versus closed, when the mouth is open, the tongue's probably going to follow the lower jaw because that's what it's attached to. And so then you have zero force on the inside of the maxilla, right? Because the mouth is just open. But you still have all the forces, whether it's musculature, whether it's cheeks, all right, that are always there when they're sleeping, right? And if they're doing it during the day as well. So now you have this imbalance of force. You have the facial muscles and everything else on the outside pushing inward. And the only thing you have pushing outward is maybe the teeth when they chew, right? Because they are going to chew. So the lower teeth, to some extent, may provide some resistance so that it doesn't, continue to collapse. But then what do we start to see on the lower teeth as that happens? Start to see those tip inward, right? It's the effect of the net forces. Again, the more the maxilla starts to narrow, the more pressure it puts on those lower teeth, the more those tip inward, and anything it's going to move until it finds its balance, right? And so at this point, at this spot in her growth, this is where her balance was. And so upper jaw, for whatever reason, has grown smaller, more narrow, lower teeth have tipped in to compensate, and this is where she's at, okay? So deep bite, what are we going to check for with the deep bite? You're going to check for where? Again, not super obvious in this photo. What about crowding, not crowding in this case? Okay, crowding. Let's start with the maxilla, right? So we know we're good from like the canine to the second molar because we have all those teeth. So looking here, we have a couple millimeters of space, but then we have a couple millimeters of crowding, all right? Now, the upper teeth are retroclined a little bit. We can see that. You can see the facial surfaces of them, right? So maybe that gives us a little bit more room. And then here you can see probably not enough room for an entire lateral incisor. So if you had to say mild, moderate, or severe crowding on the upper, what would you say? Mild, I would agree. Yeah, so a couple millimeters, right? On the lower, again, we mentioned that the lower teeth had to tip inward in order to compensate. All right, that's what happened with the balance of the forces as she grew. All right, so now we're good from the second molar to the canine here, but now we have our 3 incisors, 1 millimeter, 2 millimeters, 3 millimeters, and probably at least another 1 or 2 there. So maybe more moderate crowding, would you say, on the lower? Okay. So now that we know there's crowding, what are the 3 things that we want to tell the patient and the parent about that could happen? And what are the 3 things that we want to watch out for when there's crowding? Went over them last time. What could happen if you don't resolve crowding? What are the 3 kind of biggest things you want to pay attention to that might happen if you don't resolve it? Okay. Yeah, go ahead. There was 2 of them. And future extraction of permanent teeth, right? So we're going to want to look at the pano and see, is there some sort of impaction happening? Is that starting to form? Is there root resorption happening, or is that likely? And are we going to need permanent teeth if we don't intervene? Extracted later. Now, are we going to need permanent teeth extracted? Probably not with 2 or 3 millimeters of crowding, right? On the lower, harder to say, okay? And if these teeth don't have enough room to come in, most likely thing is impaction. Second most likely thing would be ectopic eruption, right? The canine erupts somewhere other than the middle of the bone where it should. There were some studies done years ago that actually showed they took images of younger kids that were growing, and these ectopic eruptions, these canines would start to erupt out of the bone even at the ages of like 4 years old. It was crazy. They would already, because there was no room at that point, they would already start to move outside of the cortex as they were coming in, and you would see these, basically massive holes down here in the bone when they actually imaged it. So yeah, definitely not going to fix itself, but we have to determine how much of a problem it is or isn't going to cause, and are we going to intervene. So let me see if back up here. So what would you do in this case? Treatment-wise, what are you thinking? Okay, so if you expand if you may be an expander, what does that do for you at this age especially? What are you going to get? What is that going to change? Okay, so you're going to change the width of the maxilla. Again, and we'll go through, how we measure these out. We went through that last time. You could actually measure it on a cone beam, but just eyeballing it, you can definitely see, okay, well, aesthetically that would improve things. From a crowding standpoint, that would help things, right? We have more room there. And not only would it help on the upper jaw, which we noted had mild crowding, but how would that potentially help with the lower teeth? Right, okay, so now we can set them up in a situation where the lower teeth can then be uprighted either at the same time the expansion happens or over time with the tongue being able to push those lower teeth out, because now we don't have as much force from the maxilla pushing those in. Okay, so that's what we did. This is post-expansion, post all the rest of the teeth coming in. Okay, so also pretty decent situation, right? We've made room. Palate still a little bit more vaulted, but definitely not as much as it was. Buccal corridors, much more full. And again, bites a little bit deep, not as deep as it was. So now we're in a situation again where treatment becomes optional. How straight do you want the teeth, right? There's no functional issues. If the patient's happy with their smile, you're good. They can go on like that. Still a little bit of crowding in the top, still a little bit more crowding in the bottom. All right, this patient chose to have treatment, and so we went ahead and finished aligning everything, and we moved on. Okay. All right. So no more help on this one. So you guys are going to diagnose this case, and then we're going to see how we did with it. Okay. So this is your patient now. What do you see? What are you worried about? What's your problem list? Okay. Deep bite. We're going to check for the lower incisor. Where? Okay. Again, it's hard to tell in these images, but does this look better, worse, the same as the other images? I heard worse than the same. All right, I'm going to go ahead and agree with worse. Do you see here, if you look closely, you can almost start to see the little line of dentin on the mesial incisal edge here. And overall, these edges look a little bit thicker than the patient before. So again, not the best photo in the world to describe it, but I'll just tell you, yes, there's wear on these lower incisors, okay? All right, so what else? What's that? Okay, poor oral hygiene. That needs to be addressed, right? What might you do to educate them on that? Yeah, and honestly, they probably had this education before, right? If they've seen the dentist before and went over and over. What I like to do is either give them or recommend plaque disclosing tablets, because I feel like they're underused, but it's a very visual way for them to see it and kind of like not be able to deny it at that point if they use it, right? So we'll give it to the parent and just say, hey, look, plaque is the same color as the teeth. It's very hard to see sometimes. This makes it very easy to see. So brush your teeth like you normally do, and then chew up one of these tablets, swish it around, or if there's liquid solution trace, you can put a couple drops under the tongue, swish it around, spit it out, and then just go back and brush everything until all the pink's gone, and you're good. So do they use it? I don't know. But to me, it's like it's a very good way for a parent to be able to know as well, because if a parent's looking, they may catch some of the obvious stuff, but they're not going to catch minor plaque accumulation, right? That's something they're not going to see. And so having that as a resource can help them. Okay, so we're going to coach on oral hygiene. All right, what other things are you seeing here? What's your diagnosis here? What's that? Okay, so we got a little bit of, which may be, why? Why might that be inflamed? Okay, it could be an impinging bite. We have the deep bite here, so it might be impinging there, right? So what could potentially happen if that is the case and there is impingement? It doesn't happen very often. I've only seen it a handful of times, but it can happen. Yeah, you can have recession, right? You bite down here and you start to have recession on the lingual. Most of the time, it's just going to stay inflamed, and it is what it is. But with severe cases, 100% you can, and especially in proclined severe cases, you'll start to see those incisors hit on the cingulum, and you can start to have recession and or mobility of the anterior teeth. Okay, so we have that. What else do we have? We talked about the buccal corridors on the last two patients. What are you guys seeing here? Like, okay, all right. So, like, maybe okay, not as bad as the worst of the two cases, maybe not as good as the better of the two cases. Okay? And what about our crowding assessment? Top versus bottom. What's that? Okay, top might be a little bit better than the bottom. We know we're good from canine to second molar here. We have canine to second molar here, but we have quite a bit of overlap, all right, in all of these. Now, thankfully, the lower incisors haven't proclined to the extent where the gingiva is super thin here, okay? So which of these things, and whenever you're talking about phase one, the justification for phase one needs to be, if we don't do something now, things are likely or could get worse later, okay? So which of these problem lists, if we don't do something now, are likely or could get worse later? Okay, so this could get worse, and these could get worse, okay? Between those two, I would say these lower incisors wearing down are much more likely to get worse. I mean, you think about that. This patient is pretty young. They don't even have their lateral incisors on the top yet, and they already have significant wear on the permanent lower incisors. This process is happening fast. Now, could it just stop? And, maybe they stop grinding, or yeah, it could, but that's very unlikely, okay? The most likely thing is that whether it's chewing, whether it's grinding at night, whether it's both, whatever's going on is probably going to continue to go on, and that rate of wearing down the teeth is probably going to continue, okay? So for the wear on the lower incisors, what might we do to prevent that? What's an option to prevent that longer term between now and the time that she is ready for full treatment? Yeah, you could do a night guard. You could do a Holly with a bite. The Holly is nice, right? Because or some type of retainer that only covers the permanent teeth, or not many of the baby teeth, because whatever covers the baby teeth is going to fail, right, when the baby teeth come out or have to be adjusted. Okay, so you have a Holly, you can do that, you can manage that, or any type of retainer that you can adjust, or you just make them over and over again as the baby teeth fall out. But that will address that specifically. All right, what about our crowding and buccal corridors and what we didn't talk too much about, the slight tipping in of these lower teeth? And we'll go through some x-rays to look at it in more detail, but what might you be thinking for that? Okay, you might want to do expansion, right? We make the upper jaw wider. If anything, that helps our buccal corridors. Upper jaw might come down and forward. Doesn't really need to come forward too much. Talking about the nasolabial angle, that looks pretty normal. Lower jaw does seem a little bit more recessed, but certainly coming down a little bit is not going to hurt the smile show. If anything, it might help it. Let's look at our pano now. Does this shed any more light? Right? Now what are we thinking? What are we worried about when we look at the pano? What are some things that stand out that's like, oh, that might be a concern? Of what specifically? Which canines? Yeah, right? This doesn't look great. And so we talked about the narrow jaw possibly being one of the reasons that this might happen. What other thing do you notice in this image that might be like, oh, dang, like maybe that's affecting it as well, that you couldn't really see in the other images that now you can see? Okay, there's some lower fives, but let's stick up here with the canines. So we have a lack of space for these canines. We mentioned one of the reasons is a small upper jaw, but what else can we see now? And magnification may affect it a little bit, but what else can we see now that might contribute to having more crowding than we thought we had when we were just looking in the mouth? Yeah, I mean, they look kind of big. So now again, it could just be that these are, more palatal, but probably not, right? I mean, that's quite a bit of magnification. I mean, they look bigger than the centrals. Now, they probably aren't actually bigger than the centrals. You can look at a cone beam, but for sure, they're not peg laterals. They're not undersized laterals, right? So we have a situation where it's like, well, these teeth, if anything, look a little big. So now you've got like a jaw that's a little small and teeth that are a little big, okay? If we don't do something, maybe we have impaction. What about root resorption? Are we worried about that, like in this case specifically? Is there a lot of concern for root resorption? Why or why not? So the angulation of the canine, that's certainly something that could potentially cause root resorption. So that is an argument for why you should be worried about it. What are some arguments why you might not be worried about it in this case? Yeah, they are past the apex by quite a bit, right? And you can't see it 100% definitively, but the apex is somewhere up here, and the crown of the canine is all the way down almost to the CEJ already. So the incidence of root resorption in cases like this is very, 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 very low, okay? Could you have resorption on the lateral part of the root? Yeah, possibly. Would it be significant? Almost never, okay? So, from a root resorption standpoint, that's definitely not my number one concern, but from an impaction standpoint, very, very likely on the maxillary canines. Now, you brought up the mandibular second premolars, okay? So, and you mentioned that they're distally tipped. Is that normal or is that not normal? Yeah. Yeah. So with lower second premolar specifically, you will often find that they start more distally and they start more lingually, and then they tend to make their way upright and more mesially, okay? So having them start here, like this at this stage at least, is not a huge concern at all for me, right? Because they typically, and it's actually not a bad plan if that's how Mother Nature planned it, right? Because we know we have E-space here. We want to save as much of it as possible. So if for whatever reason they're programmed to kind of, erupt more distally and then move more facially afterwards, that's a pretty good plan to be able to save as much space as possible. So now, could this become like distally impacted or impacted to the lingual? Yeah, it could happen. Doesn't happen very often. Yeah, not very often at all. And more often than not, if you get really worried about it, let's just say it keeps getting worse, my guess would be a couple years from now, this would upright on its own and you wouldn't have to do anything. But let's just say it didn't, and this was like totally jamming into this first molar here. You extract the primary tooth, space maintenance, and almost every time it's going to come right in. Okay, so not a huge concern there. All right, so we have bigger teeth, we have a smaller upper jaw. Let's look at this here. All right, this was our deep bite. You can see now, skeletally, the mandible doesn't look as retrusive as it did in the profile view. That may be in part because the way that this image was taken, you can see that the head is turned up a little bit. The mandibular length doesn't look, it looks a little short. We didn't measure it out here, but it looks a little bit short, but not terrible. You can see that the patient is in, class 2 molar right now, and you can see the deep bite in the lower incisors hitting here. Any other concerns about the relationship of the jaws on the Ceph? All right, let me ask you a different question. So, if I told you that this Ceph was taken with perfect head position, all right? I just told you that. I said, hey, look, this was perfect head position Ceph. What do you see on here that you might be worried about or that you might want to take another look at? In this general area here. Okay, maybe. Yeah, well, yeah, but on a 2D, you can't really get too much from that. Maybe a little bit of the adenoids here. Tonsils are very, very faint, hard to see. Overall, that looks pretty good. I wouldn't be overly concerned based on this, nor would I encourage you to put too much weight in a 2D or 3D volumetric analysis, but definitely not 2D. So I wouldn't be worried about that. But, and this is something we haven't talked about today or maybe ever with you guys yet, but look at the Ceph. What are you seeing that's a little unusual? Okay, yeah, what are you seeing that shows that, again, it could just be that the head is tilted, right? And probably that's what it is. But let's say the head wasn't tilted. What's telling you that?
The lower corners of the mandible don't match up.
All right, awesome. All right, we have our golden ticket answer for the day. Pass that back to her. Okay, yeah. So this is something that you want to pay attention to. Maybe it's the Ceph, but when you see that, that's a pretty significant discrepancy here, right? And so maybe one side is longer than the other. There's a couple other things you can look at to verify that. You can look at the length of the condyle to the mandibular angle here in the pano. Right? You can actually measure that if you have software that can you can put a ruler on this, but you can look there. And then also you want to look at the midlines, right? The dental midlines. Is it shifting over to one side? You want to look at the chin. Is that shifting over to one side? So yeah, when you're going through your images, we were focused on the deep bite, we were focused on the AP, but keep an open mind to what else you might be seeing there. Okay? So we've gone through everything now. What are the treatment recommendations for this patient? Who wants to volunteer to treat this patient for us? Nobody. Birthday girl. How are you going to treat this patient? You can be honest. There's 40 people, 30 people in this room. We all might have a different way we treat this, and that's okay. We've talked about the diagnosis. If this were your kid, what would you do? She's like, I don't want kids ever. No. Well, we talked about the wear on the lower anteriors, and we talked about the jaw size. Those are probably the two biggest things. We talked about the potential for canine impaction. Okay, so if you believe those things, what might you do? Okay, you would expand. And what would expansion do? Okay, so you're going to create arch length and space in the upper jaw. which is going to be redistributed with the teeth as they erupt. So you will absolutely make room for those canines more than they have now. Is it enough to prevent impaction? I don't know. But you could expand and make more room that way, okay? What else are you going to do? You've done the expansion, and you take the expander off. What else? What's that? Okay, you could do a bite plate to prevent and also to maintain all of the space that you've created, right? So you maintain your arch length dentally, right? Skeletally, after the expander comes off, that bone should be set, filled in with new bone, hardened, all those things. All right, so we're going to maintain the arch length that we have, and we're going to prevent the lower incisors from wearing down with a Holly with an anterior bite plate or something similar. So that is exactly what we recommended. And so now we're going to fast forward 4 years, and let's see how we did.
Do you do a bite plate on your expander too in case like that?
So I use bonded expanders, and so there is acrylic occlusal of the teeth, and so that opens up the bite there. So that's going to prevent wear while they're in treatment. So the short answer is no. Yep, and then once the expander comes out, then we'll put the retainer in that has the bite plate. Okay. How did we do? How do our canines look? What's that? Yeah. Or another word for that might be like impacted. Yep. Yep. And our lower fives came in. All right. So that's good. You can see rotation of the lower canines as well, like quite a bit of crowding. What about the edges of the mandibular anterior teeth? Okay. How about our deep bite? Did we do a good job correcting our deep bite or opening up the bite? We still have our potential asymmetry here, or bad head position Steph, one of the two. Okay, so this is what things look like 4 years later. Now you can definitely see more wear on these incisors. All right, the lower teeth are tipped in more. Okay, so what happened here? She didn't do treatment. Yeah, right? So our job is to educate, right? We let patients know what we see. It's up to them to decide what they want to do with that information. Now, they were aware of the risk of impaction and all those other things that we talked about. Hygiene, you can see, didn't improve very much either, okay? So, who knows? I don't know what happened. I mean, most of the time, they never come back, so I never get to see, what happened, but this patient did. So, and in the grand scheme of things, my opinion is this definitely could have been worse than it ended up, okay? So let's see how it ended up. So, yeah, hygiene's not great. We're working off of a somewhat compromised result here. We have additional risks if the canines need to be exposed. There's surgical risks. There's additional costs there. We know that the incisors are worn, and so although we can align them, that's not going to change, right? They're going to remain worn. But this was her result after the treatment was completed. And, overall, not bad, okay? Now, we didn't end up being able to correct the upper jaw entirely. We corrected it to some extent, but there's still a jaw size discrepancy. You can see that the upper teeth are tipped out. I mean, overall, patient's happy with their smile. There wasn't complications with the canine, so those were able to come in. The lower teeth are worn, okay? And I would say this is an argument. Like if I showed this case, that would be an argument for, hey, you don't need to do early treatment, right? Some people would look at this and say, why would you do it? Okay? And some people still look at this and say, why would you recommend treatment earlier? All right? And my argument to that would be, in a lot of ways, we got lucky, for one. And then in a lot of other ways, we still don't know, right? We're not like completely out of the woods. There is an underlying jaw size discrepancy. The teeth are compensated. And the incidence of tooth wear, fracture, TMJ, all those things is higher when the jaws are not aligned. Does that mean she's going to have all those things? No. She might continue to get lucky. She might go her whole life with no problems and a nice smile and a nice bite that she's happy with. Or she might not. Right? So if it's my kid, I'm going to try to do everything I can to make him the least likely to have problems down the road. Okay? So, In that case, I would have expanded and done everything that we talked about. All right, that's the where on the lower incisors. You can see that a little bit more here. Okay, you can see the compensations, the tip teeth on the top, outward, lower teeth inward. That's what they needed to be in order to fit. Okay, and then this is the final panel there. See, eventually the 8s are going to need to come out. Okay, here's our final Ceph. We had some growth that helped us. Still maybe a little bit end on. All right, final airway, no real issues there. And then final jaw size. Okay, so again, upper jaw a little smaller than lower jaw, compensations there. Hopefully no issues, right? Hopefully they go their whole life, no issues, you know, you never know. Okay. Yes. Yep, just brackets. All right, we'll finish up here. This was a video I put together like 5 or 6 years ago, and like trying to like educate patients about like different changes in orthodontics and whatnot. But it's already kind of outdated, but I'll show it to you just because it's kind of fun. A lot easier to see what's going on Comey. This is called anatomage. They create STL files of each of the teeth and the jaws section from a cone beam, which allows you to actually treatment plan and move those teeth. So you can actually project proclination, crowding, treatment plans, whatever you want. You can see it within their jaws, what that's going to look like, and how much bone they're going to have. In this case, we treatment plan expansion, consolidation of space. You can see hereditary shortening of the anterior roots, never had treatment before, just developmentally small. Tons of systems. This was like, there's only like one system back in the day that would do this. Now there's like a lot of systems that do what we call digital indirect bonding, which means scan the teeth, put the braces on where the teeth are supposed to be, where you want them to be, and then reverse engineer everything, right? Lots of systems that do this now. When I made this, it was pretty much just this one. 3D printed trays now. We print these in our office. We don't have to order them from the lab anymore. The idea is to get the brackets on the right spot. This system specifically even took into consideration torque. I don't think it's even around anymore. It's insignia by Dave and Ortho. But pretty accurate. You guys are all familiar with clear aligners as well. So there's over 100 clear aligner companies now. Obviously Invisalign was the only major player in the game for a long time, but a lot of the newer companies have a ton of innovation and even more than innovation, customization. You can customize things like you've never been able to before, so that the cases that we can treat, the times we can treat with clear aligners have gone way down. The cases we can treat have gone way up as far as what we can do with them. But we'll go through next month a little bit more about figuring out why you do what you do. Each one of you became a dentist for a reason. You became a specialist for a reason. And that reason is probably the most important thing that you'll want to define for yourself, because that reason is going to be the biggest maker or not of your own success and for the health and well-being and success of your patient. So our thing is like, we change the smile, you change the world. We'll talk to you guys more about it next week, but any questions as we wrap up today?